Hello, and thank you for... Oh, that's terrible. Ready?
We're keeping that.
Hi, this is the Reservoir Geek. I'm Andy, and that's Chris. And we're speaking with Danny, Dr. Daniel Zamora, again for COVID-19 round 2. I was looking at some numbers just to let people know where everything is in case they watch this later and they stop counting. When we released the last episode, so it was the 18th of April, there was about 2 million cases and 159,000 deaths. And now on May 4th, we're just, like 2 weeks away from that. We're up to 3.5 million cases and 250,000 deaths. So the numbers are still going, and now we're at a point where states have started to reopen. Has any state opened all the way yet?
I don't think so. Because I think some states have gone the restaurant route, some have gone retail, and then some have gone as far as going like salons and barbershops, nail places like that. I don't think anyone's gone all the way, but I did see something about one state that was thinking about resuming concerts and functions like that.
God.
Yeah. Oh, and some states, I guess, have opened theaters as well. It's kind of fuzzy, even here in our city, Dallas. Like, we're still kind of like, what's open and what's not.
Right. Yeah, Texas just reopened this past Friday, May 1st, for its 25% occupancy, and no movie theaters open. Except
Even though they could, right? Weren't they able to? They just didn't want to.
Right, they just didn't want to risk it. And also, I think financially it would be stupid because the movies they can show are so limited and old, or they're out of contract. And if you're only selling 25%.
Yeah.
So, but
what's it like up there, Danny? Because you guys you haven't opened.
No, not yet. So I think the projected kind of, we've extended the stay-at-home order until at least the end of the month, and but there is a plan that Governor Inslee has laid out that in terms of opening up Washington in phases. So, for example, and I have to be honest, I haven't looked fully at like the timeline of what things are gonna, like how things are gonna open up here, but I do know for sure, like I think tomorrow that a lot of parks are going to open back up, so that's going to be interesting. But we went for a drive the other day because we just had to get out of the house, and we're driving past. It's called Alki Beach. It's a little beach that's over here in West Seattle, and it's there's obviously some park locations next to it, and I was just kind of surprised at how many folks were out and about. It was a Sunday, so I'm sure it would have been busy either way. But there's all these signs up saying like keep it moving. They don't want people to actually
to hang out.
Exactly, and they were, and unfortunately there were some folks just kind of having a picnic on the beach, and but yeah, we're learning a little bit more just about the virus to say it's probably okay to do outdoor activities, but that keep it moving kind of thing is probably is going to be key. And there's also science that are giving you the measurement of 6 feet, and but we'll see how it goes, but it's a slow process over here.
And what's the outlook looking now from like the medical field, as far as like, last time I think you had said you couldn't imagine a concert being until 2022. Is that still like the idea, or
or
more?
I think that it's still ideal from the scientific community to put off those types of large gatherings as much as possible. I know that I heard the same, Chris, about there was a state that was thinking about doing or opening up concerts again, and it seems like it's going to be a little bit of a watch and wait kind of thing, and see what the citizens even want to do in these states.
I mean, I can say personally, I'm a person that likes to go to concerts, I like to photograph concerts, and I have a lot of friends that are, in the music industry. And I think even if venues were to open up, I'm pretty sure they would still be kind of hesitant, even though, they're dying to get back out there. And that's how they make money. They're still kind of hesitant about doing it, because one, I'm sure they don't want to get it. And I'm sure they don't want anybody else getting it because they all went to a show.
Right.
Yeah. That's why I just can't imagine theaters, because it just feels like it's the same thing. You're packed in like sardines, 1-2 feet away from the next person's face.
I saw another state that was thinking about doing these like almost like a drive-in theater kind of concert thing. That's kind of an interesting concept, but definitely not green. So I don't know how that's going to go.
Yeah. And then how do you like honk out in Morse code Freebird?
Instead of a lighter, you could probably just flash your highlights. I guess.
Yeah. Blind the guy on stage.
It's going to be somebody constantly trying to inch forward or inch past you to go to the bathroom. And then the car just opens their doors just to kind of hold the spot of whoever's peeing. All right. Well, I guess before we jump into questions, what new developments have there been that you've seen so far?
Well, I think Andy hit a big highlight is just the number of cases for sure. I think those numbers that you were mentioning were worldwide. It sounds like because in the U.S. Right now. I actually did the same thing that you did, Andy. I was looking at what the numbers were when we talked last and what they are now. And
right.
It's essentially doubled. Really, it was almost like 25,000 deaths here in the U.S. with 500,000 cases or so. Now we're over 1 million here in the U.S. cases, and we're at 68,000 as of this morning cases. Or deaths that rather. And so things are not going the way they should. And it's worrisome with this whole reopening. And that's another thing that I guess that has, that was a new development, was the kind of the federal response with laying out these guidelines of how to open up states, and it was really up to governors and to figure out how they want to do this. But unfortunately, there was a little over 30 states who are thinking of reopening right now, and none of those states have reached the guidelines to actually open up based off of the federal guidelines. And so. And that those are important actually, because that particular part of wanting to see cases on a downtrend, that it's we may have caught up with our some places may have caught up with their hospital utilization, but the cases still matter. It's still a matter of transmission too, and other things that have kind of been in the news have been, new symptoms. We're learning about new complications that COVID can lead to, leading to different clotting issues, strokes in young folks, and I think there's some questions about treatment too, and we can get to that for sure. But there's been some headway there too, but really nothing, nothing very fruitful, or nothing very optimistic, I guess.
Yeah.
I think things are still we're still in a lot of the we don't know kind of stage for a lot of these questions.
Mm-hmm.
And we're kind of in a waiting phase, at least for the next few days, because most states started opening at the beginning of May, May 1st. And because it takes a while before people start to show symptoms, if they do show symptoms, it might be another week before we finally see what I wouldn't say fallout, because we don't know if it's going to be bad, but what the effects are of these states kind of loosening restrictions and stuff.
I mean, I think we can confidently say actually that
Numbers are going to go up.
Yeah, they're going to go up, and
Yeah.
that there was some press about how like states like Georgia, for example, the day after opening, they were at 1,000 new cases, and okay, sure, those were not attributed to the actual opening.
Yeah. There were a lot of reports that were floating around like that, and I wanted to say, oh, you got to pump the brakes a little bit, because that's not because of opening. It's just that doesn't point in a good direction.
Right. It's not because of opening, but that is, I think we talked about, transmissibility and the fact that, one patient can infect at least 2 people. And and it's just an exponential growth.
Yeah.
And so if you take 1,000 going into opening, that's bad news.
All right. Well, you want to jump into some questions now?
Yeah, let's do it.
Yeah.
So we had one, but I think we'll wait and hold that towards the end. Do you know what the standard is for saying a patient is now negative? Do you retest? And if so, 1 or 2 negatives? If they result as positive, is that reported as a positive case in databases, or are those simply new positive cases? I'm guessing. I'm guessing they're asking if they retest and they show up positive again after that.
Yeah, so they more than likely will not be counted twice as like 2 different cases.
Mm-hmm.
But to answer the first question, unfortunately, it's not standardized just yet. The CDC has actually 2 different strategies of how to declare someone kind of safe to go back to work kind of thing, and non-infectious. So the first one is based off of basically like a timeline of symptoms. So you need to have been without any fevers for 72 hours, and at least 10 days from when your symptoms started. So, you're looking at at least 2 weeks of, being out. But, the other hand, though, is with using testing. If you do use tests, it's recommended to do 2 tests. So you need 2 negative tests within a 24-hour period, so that you can say that you're not, you're not infectious. But there's a big problem with that type of strategy, and that's really something that we talked about last time, was that these tests, these molecular tests, are they're picking up genetic material, and so it's not really, you can't equate it to an infectious virus. So just because you're finding it, you're finding a positive test, it really doesn't mean much. And there's been some studies actually that there's been folks that have actually turned up positive from their nasal testing up to like a month out. And
Oh, wow.
Yeah, and we don't know what it means. It's really, and it's really more likely that the 2 weeks is a more sufficient thing. But yeah, so there's two strategies, and it's it's based off of which organization you're at. For example, here at the University of Washington, we go based off of the symptom thing. We don't do the test of cure thing.
Mm-hmm.
All right.
Well, yeah, you were talking about genetics. Do genetics contribute in the severity of symptoms any person may experience?
That we don't know still. what's probably so. I mean, there's multiple organ systems and factors that kind of play into someone's underlying health condition, and so someone may have genetic predisposition to doing worse from pneumonia, or not necessarily from COVID specifically. So I think it's going to be a while before we see those kinds of data, and it may be that we're even we're past COVID and we don't figure it out until kind of after the fact. But I think the more concrete data of I have X condition or a Y condition, those are the things that that we know are probably markers of bad outcomes.
Why is the treatment for the virus different across country and the world, even from country to country?
A lot of that was, I think it was we just didn't know what was going to work and what was going to work.
So just kind of early stages. So
yeah,
people were trying one thing and others were trying another, and
it's bad terminology, but sometimes we call it throwing the kitchen sink at patients. And
what if that is what it takes? Have you guys tried just throwing kitchen appliances at the people?
No, we haven't tried it, but what would be the placebo for that, right? I don't even know.
Throw a person at a sink.
Well, if you could design the study, then I don't know. There's a promise for everything these days, to be honest.
All right, I'll try.
So yeah, so some countries were just working with the resources they had, and China, for example, there was these studies looking at we talked about this last time, hydroxychloroquine, and they were looking at some anti-HIV medications. There's this medication called Kaletra that they were using, and sometimes they were using both at the same time in patients, and sometimes they were using steroids in patients, which we know can actually make patients more sick when we use it when they have an infection going on. So I think a lot of it was, in the beginning, we didn't know, and we just really wanted to do anything to help. There was no randomized controlled trials that had been organized early on. They started to get more organized as time went on, and I think there's different countries have different standards for research and for their randomized trials, and more and more we're having folks with from professional societies that one of the societies that I'm in is the Infectious Disease Society of America, or IDSA, and we released some guidelines basically saying if you're going to try anything, try it in the context of a randomized controlled trial, because otherwise you using a medication is not really helping generate the data that is useful for these treatments. Mm-hmm. And really, there's been an argument that when we use a medication and we don't know if it even works for a patient, it's really kind of on par with just treating ourselves and making us feel better.
To your knowledge, are COVID positive patients being put on ventilators prematurely? And if so, could this lead to death?
Yeah. So, there's been some press about this, the same question about were we really doing patients a disservice by putting them on the vent early? And I have to preface with, I'm not a pulmonologist. I'm an infectious diseases doctor, and but what I've what I've kind of gleaned from, working with my colleagues who are pulmonologists is that there's been some rethinking about, what exactly is going on with the mechanics of the lungs during the disease. So that so SARS-CoV-2 leads to COVID, the disease, and that disease can lead to a syndrome, a lung syndrome called acute respiratory distress syndrome, or ARDS. And so there's a lot of things that actually can cause ARDS, infections, trauma, even having a burn injury can cause this. It's just a kind of a inflammatory response in the lungs, and we talked a little bit about this last time too. But so what some studies have shown is that so it looks a lot like the ARDS syndrome, but that their lungs actually are a lot more elastic than what usually is kind of the norm for ARDS. And what that means is basically, for all intents and purposes, that the ability of the lungs to expand. So it's actually better for some of these folks with ARDS from COVID. So, and then there's been actually some more push to actually use other non-invasive oxygen strategies. And here in UW in particular, we're trying to do like what's called high flow nasal cannula. And so it's a very, you've seen folks with like oxygen and a nasal cannula, and they're pushing around an oxygen tank. This is like that on steroids. Like they actually have to hook it up to a wall because the oxygen tank isn't enough, doesn't have enough pressure to have those high flows. And so, and even the cannula that they use in the nose is pretty heavy duty. It actually fits like the whole inside of their nose. And we weren't using that at first because we thought that using that would actually help spread the virus in the air. But there's been some studies that have been showing that may not be the case. And so really, some of it in the beginning was that we just didn't know much about the disease process, didn't know about the mechanics of the lungs, didn't know how careful we needed to be to protect other patients and to protect ourselves. So, but I don't think that anyone should necessarily jump to any conclusions that we were, putting these patients on the ventilator too early. And I think there's probably more often than not a lot of times where they actually need that help. And there's even been some interesting ways where they actually can increase the oxygen in some patients where they actually let them lie on their stomach. And that's what you call proning a patient. And actually, so that what that does is it allows more oxygen to be delivered to parts of the lungs that are not affected by the disease process. But so it's been kind of interesting. I think you guys know that I've spent a couple of days in the ICU and here in Seattle, and there's been some patients that are on the ventilator, but they're on their stomach. It's just crazy to see.
All right. And now when we flip over, you could give them a back rub. I mean,
maybe that's that should be part of the treatment, right?
Isn't that part of your bedside manner? You're supposed to give back rubs?
I mean, that sounds better than a kitchen sink.
Hey, out there, listener land, wash your hands. It's real easy. You should probably do it even when there's not COVID around. Because nobody wants to shake hands when you just went pee-pee. Wash your hands. As more numbers are released, and you touched on this a little bit, but I guess just to solidify it, as more numbers are released, is your perspective on the severity of the virus changing at all? Why or why not?
Yeah, we did touch on it a little bit, and I think with the doubling in cases since the last time we did this, I think it's been pretty sobering. And the fact that we also talked about this too, but that um, that whole time, where that doubling happened, we had social distancing measures actually in place, right? And even with those measures, it's still doubled. So if you can imagine what's going to happen when we get rid of it, like I can't even imagine. It's pretty scary.
Yeah.
But and then some of these other things, like I said, of finding these other complications. There's been an interesting new one, and I don't know if you guys have seen it in mainstream media about COVID toes. Have you seen that?
Yeah, yeah.
Yeah.
In children mostly, right?
I think it could be in anyone.
Oh, okay.
But it's so yeah, it looks like almost like folks have frostbite, and there was just some reports in the past couple of days about, and then again, these are case reports or anecdotal. You would need to actually do like large studies about it, but that actually may be due to the clotting issues too, and that there's little microclots that are happening in the feet that are causing these toe manifestations. And some folks actually will get the toe thing without even ever having the respiratory stuff.
Is that is that type of, I guess, skin reaction, is that typical with other viruses at all?
Not really. Not with respiratory viruses, at least, but there are some other viruses like varicella or the chickenpox virus that they can cause a vasculitis type finding, but that's more of a like inflammatory thing, not a like it inducing a clot kind of thing. So,
Gotcha.
but yeah, the jury's still kind of out about whether that really is related to clot or not. But we are seeing that, and actually you had just mentioned a little bit ago about skin stuff, and like apart from that, there has been some cases where folks are getting some rashes too. So, and that's pretty common with some respiratory viruses.
Since we're actually on the subject of skin, the person asked, I read today that a person can contract COVID-19 through an open wound, like a crack in the skin. Is that true, or is that bad info?
Yeah, probably not likely. But there has been detection of the virus in blood, and I think there's even, there's reluctance to use blood products from patients when they're sick, like actively sick anyway. But there's been no evidence to suggest that the virus that they're picking up in the blood is, actually live virus. Again, this is all genetic material, so it's. But to answer that question, no, I don't think it's transmissible through a cut. But we find it there. We find it in weird places.
Because it's the best way for it is to go through the nasal passage or the eyes or the mouth, right? Like that's its pathway into the body.
Yeah.
So you could get it in a wound, but it's not going to necessarily infect you that way unless you're like licking your arm or whatever.
That's actually you're heading in the right direction with your thought process there. That the virus relies on certain receptors, and we didn't talk about this last time when we were talking about kind of the general virus characteristics, but there's these receptors that are located kind of in the respiratory tract, the oropharyngeal tract, and the lower respiratory tract. It's called they're called angiotensin converting enzyme receptors, and this is actually an enzyme or a protein in the body that's targeted for blood pressure medicines. And so there's actually been a lot of concern and debate whether or not that people that are on these blood pressure medicines, whether they're at increased risk of getting COVID. But we haven't seen any evidence of that. But anyway, so that these ACE receptors are located where I was saying, but there's also some located in the gastrointestinal tract. And I think, in terms of like in kind of periphery, not so much. There are some actually located in the nose too, so that's actually been the proposed mechanism of why people are losing their smell. And it's also a proposed mechanism of why babies don't have as severe infection as older people. We talked a little bit about this last time, and I said that there's been some thoughts that it could be due to your immune cells aging, but there's also thoughts that babies have less of these receptors in their lungs. So it's just another theory out there.
Because all those three holes are connected.
Yeah.
And I know that because you can cry milk if you try hard enough. Because I've seen it. And I tried
I knew a girl that could make it come out of her boobs.
It's crazy.
Just out of curiosity, you're a smart guy. Well,
you don't know that for sure.
First, I'll lead with.
Thank you, by the way. Thank you.
Oh, sure. Like I've used a neti pot, right?
Mm-hmm.
So if I think like, ooh, I was at the store and that guy was coughing a lot, could you flush out your nasal cavities with a neti pot?
No, I mean that's kind of akin to some of these like myths of can you just gargle water, and then just get rid of the virus that was there. If it's there, it's there. It probably already did its thing in terms of binding to receptors. And
there was a lot of stuff floating around that if you like, it couldn't live in certain temperatures. So if you drank like really hot liquid, or if you like steamed up the bathroom and were inhaling that would kill it, and it wouldn't have time to get you.
You told me to do that, Chris.
I was also trying to give you the brain-eating bacteria by telling you to use a neti pot.
Yeah, just don't share your neti pot. And
I said use pond water because it's from the earth.
And that's what I did. And ever since then, I can't smell or taste. I asked you some stupid questions earlier, and I'll just put those out there because I'm a smart guy, and I asked a stupid question, so surely some moron out there has thought the same thing. Or another smart person. Would salt water air help in any way? Or is, saying it now, it sounds stupid. When I texted you, it didn't seem that stupid.
He wants to go to the beach. He's basically asking you to go to the beach.
There's no therapeutic benefit that we've seen to, being in salty environments for this, at least. And, I think actually, there's actually some diseases that can be aerosolized a lot more easily when you're kind of in that water air interface. So like for example, for folks that spend a lot of time in hot tubs, that there's a thing called hot tub lung, and that's from a bacterial infection that they're kind of repeatedly exposed to. So all that splashing at the water, like at the surface of the water, can help aerosolize some of that infection.
Okay, so that was my other question was, is it possible to social distance at a pool? Like, can you go and like swim at your buddy Doug's house as long as you guys stay 6 feet away from each other?
Yeah. So, I mean, it sounds like that's what is going to end up happening anyway from the loosening of these regulations or these social distancing guidelines. But, here in Washington, for example, as part of that new opening up of parks and things, they're actually still recommending that people just do recreational activities with people in their own household, because you know where each other's been, you know where each other's going, and there's always that question, of when you're interacting with folks outside of your household.
Like, how many people have they slept with?
Yeah, well, I mean, there's that question too, but yeah, you just don't. I mean, and it's not like it's not like a blaming or fault thing. Sometimes it can just be exposed to someone and not even know it.
Yeah. Since we're talking about the pool thing, I had seen something about that doctors were worried about, I guess, fecal shedding, that the virus was there, and that the pool was a melting pot of poo particles.
That's what a pool is.
Yeah.
I don't know what pools you guys go to, but
Public pools.
Well, it's actually, so it's similar to what I was saying about the virus in the blood thing, where yes, they've picked it up in stool, the genetic material, positive tests, but they haven't necessarily been able to grow the virus from that. So we still don't know what that means.
Yeah.
So we don't have enough data to say at this point that
People
fecal,
can eat shit and die.
yeah, well, we call it fecal oral transmission, but that's another way to put it, I guess. We don't have any evidence that actually is going on.
Another question we had sent in is, my neighbor who is 70 years old was wondering if the 2 pneumonia shots he's gotten help him somehow fight off COVID.
Probably not. I mean, then there would be a lot of repurposing for some of these other vaccines, right? And I think they're, in general, everyone should get updated on, whatever age appropriate vaccines that they need to get. But I think where the pneumonia vaccine is beneficial in this case is that people with COVID pneumonia are at risk of having bacterial superinfection, or bacterial infection on top of the viral infection, and one of the organisms that causes pneumonia is the same organism that we vaccinate against. It's a strep pneumo, and it's actually it's a common bug that's in our mouths that all the time. So we're all at risk of it, and the longer that people are in the hospital and maybe on if they end up on a ventilator, the more at risk they are for these types of bacterial infections.
What is the relationship between diabetes and COVID?
I think we talked a little bit last time about some of these other chronic conditions, like diabetes and COPD and heart failure, which they're technically immunocompromising conditions. And diabetes in particular, there's a lot of interesting complications. It really does put folks at risk of having numerous kind of infectious complications. There's folks that can get diabetic foot infections that can end up leading to infections all the way down to the bone, and that's why sometimes you'll see folks having to undergo amputation later. But and then there's a lot of these studies that have been coming out, of showing us patient data from here in Seattle, from New York. It's been anywhere from like 20 to 30% of patients that were hospitalized they have a history of diabetes. But the thing that's hard to kind of get from these studies is there's actually a wide range of spectrum how well people control their diabetes. And so that is a very important component. Like, if you're, comparing someone's immune system who has, wildly out of control diabetes, and they're on massive amounts of insulin. Sometimes they don't take their insulin. That's different from someone who is just, taking an oral medication for their diabetes, or just controlling it with diet. So I think there's a spectrum of diabetes in terms of control, and but like I said, it's just people that have diabetes are at more risk of infection.
What percentage?
Go ahead.
Do it at the same time.
Okay, ready? Okay, 1,
2,
3.
3. What percentage of the people over 65 that contract the virus recover? Do most recover at home?
I like
you guys, you weren't that good at doing that. Right?
No, we weren't. Okay, Andy, you just read it by
yourself.
No,
but I heard the question. You don't have to repeat it. I don't want you to repeat it. That's a tough question. And the reason that's tough is kind of the same stuff that we've talked about before, is that we don't know how many patients are running around with like asymptomatic infection.
Yeah.
And the way that you calculate what we call the case fatality ratio for a specific infection is that you take the number of patients who died from an infection divided by the number of cases of that infection. So that bottom number is the one part that we don't know.
Gotcha.
So if you that number is, again, the risk of dying from the infection. So if you take 100% minus that number, that's what's going to give you your probability of not dying, or of recovery. So, but I think just based off of some of the studies that have given kind of estimates of that fatality ratio, I wouldn't be surprised if it was around the range of 80% of patients. It's like not of death, but they would actually recover.
Gotcha.
Yeah.
I was like, oh
yeah.
But yeah, so again, it just comes back to testing is the whole that, like, we don't know. So there's actually no way to generate these numbers, as of right now. The only way you could is if you were able to test everybody in the United States and to test them, like, I don't know, weekly, I would assume, unless they were just staying home and no access to the outside world, which is never going to happen. So. Yeah,
I wish there could be way better coordination, kind of a national level of doing these types of studies to see how many people are infected. We talked a little bit about the antibody thing, and what is its role in kind of helping us estimate that. And we're learning more these days that a lot of those tests are not as reliable as we thought that they should be. And I talked a little bit about this too, is that it's because we kind of let them out on the market without doing kind of all the scrutiny that we usually do. But yeah, no matter what, though, you can always estimate these ratios on a kind of a more local or even hospital-wide level. And there's unfortunately some folks who take advantage of when these numbers get released, and they do the incorrect thing of trying to extrapolate those numbers to the area they live or to the whole country. You can't do that. And it's just manipulating the statistics.
Yeah, just because you have two cities with the same population density doesn't necessarily mean that you're going to have the same numbers or the same outcome depending on where they are. Like, you could have the same population density, but one might not have public transit. So that might be a huge factor in spread or how many people are infected.
Yeah, and actually, it is. You're dead on. That's a problem with New York. Actually, that's how.
Yeah, I mean that was the kind of the example I was going for. Is that you could have another city that's a big metropolitan area, but like Dallas, we don't have as big a public transit system as New York does, and that's an international hub. I mean, international center for business. So there's just tons of people filtering in and out of that place. Whereas like Dallas, we don't have that necessarily.
But yeah, and then the other thing that needs always to be taken into consideration about that. About those stats and the statistics of the case fatality ratios is that yes, it's regional specific. That's one thing. As we get more data, we can probably do like a national estimate. But the other thing is it's also age specific, and it's also disease specific. Like if you can take you can calculate the percent of patients that died that are 60 and above, or you can calculate the percent of patients that died that have diabetes, or that that all these other things, and so and then that's actually probably how people should look at these stats more than just looking at general case fatality ratio, because then they start to add in patients who are less than 60 all the way to like newborn who have had COVID, and they are obviously going to do well. So,
right. You had spoken about the antibody test.
Mm-hmm.
So we have a question that, would you trust your first antibody test, and what is the best place to have the test performed?
Yeah. So it leads back to, it depends on the test.
Mm-hmm.
Depends on the characteristics of the test. There are actually a couple of testing platforms that are actually FDA approved. We just rolled out, I think last week, a test that is available through the University of Washington, and I'm not even sure what the characteristics are of that, but it is FDA approved, and the way I know that is because we are able to share that result with patients. Because otherwise, if it's not FDA approved, then it's a research test, and we can't share those results with patients because it might affect clinical care. And yeah, I've been part of this this study, as I was mentioning to you guys earlier, that I'm part of the study that's looking at the plasma as a treatment for patients, and what we're doing in that study is we're actually we're checking antibodies using a number of different tests. So I mean, having multiple types of tests is probably going to be more informative than just having the one test. So just to answer that question, I think it just depends on the test. But right now, since there's a lot of tests out there on the market that are not FDA approved, I don't know if I would necessarily, I would take it with a grain of salt. Is what I would say.
All right, let's do one more question, then we'll take a break. Let's see. What sources do you, as a doctor, follow to get accurate information, especially about safety, moving around versus staying home, and information about who is safely and accurately working on a vaccine?
Yeah, that if you know how to use the platform, there's you can always go through PubMed.gov. That's basically the the NIH or government run research journal and paper hub. The issue with that is that you need to have access through like a educational institution like UW or somewhere similar, so that you can actually open up these articles. So if you go through there, and if you can type up whatever your interest is, like COVID antibodies, and it'll give you all the papers about COVID antibodies and whatnot. And but outside of that, in general, so different journals have what's called an impact factor. So it's basically like the rating of the journal. So, and the higher the better. And some of the biggest impact factor journals for medical information are the New England Journal of Medicine. That's where you'll find the results of a lot of big trials, like randomized control trials for treatments and whatnot. So that's one. And JAMA, or the Journal of the American Medical Association, is another big one that a lot of articles have been coming out on, and it's got a big impact factor. But the problematic thing these days is, and this has been kind of a crazy Wild West thing, is that there's been more and more articles being released in what's called preprint form. So they're actually, everyone is able to kind of read what the article has to say before it's even peer reviewed, scrutinized and whatnot from the medical community. And so, I mean, to sum it up, I mean, a lot of it can be poor studies and basically trash. But so, and I mentioned last time that you could, a lot of medical professionals also use social media, and you can follow them on social media.
All right, well, let's take a real quick break and we'll come back. We got, I think, 2 more questions.
You ready?
Yeah.
Hey guys, have you heard about this new thing? Takeout. You go to your restaurant and you eat it at home. It's just like eating at the restaurant, except your wife's there. Takeout.
All right, we got 2 more questions.
I'm assuming because I totally nailed the last medical drug question, you want me to read this one?
Yeah, sure. Do you want to read this one?
Yeah.
Is it about injecting disinfectants?
No.
Oh,
Okay.
okay.
Andy already tried that.
It did not work at all, because I tried to use it as an enema.
Oh.
But also, Drano works the other way, just so you guys know.
What about a light, a flashlight? Okay,
there is a
He
comedian.
swallowed a glow stick.
There's a comedian hold on, Chris, you might have to edit some of this down. There is this comedian that I found, fuck me thing. And
Is that the part I need to edit?
No, my computer froze. Anyway, he said, okay, so there's this comedian, I wish I could think of his name so I could credit him. And he said, I heard shining a light up my ass will help get rid of COVID, but is it going to also kill that hamster?
That was a 6 out of 10.
Hey, Dr. Zamora.
This is the question.
Okay.
I hope you and the family are well. What are your feelings about remdesivir used to fight COVID-19? I know they used it originally to fight Ebola, but it didn't work.
Yeah.
The drug again is called remdesivir.
Isn't that the band that did the soundtrack for Stranger Things?
No, you're thinking of.
Oh, it's actually exciting. Remdesivir. You almost had that one too.
Closer than Coliquaquinum.
Yes. Let's not even talk about that one anymore.
That's done, right?
Not necessarily. We're still doing we're still having some randomized controlled trials of that, but there's been a lot of data to suggest that it's not doing much, but it might actually have a role. The hydroxychloroquine might have a role in post-exposure prophylaxis. So meaning you got exposed to someone who had COVID, and then you take it, and it prevents you from progressing to COVID. And also,
like the morning after pill.
Yeah. Except no one. Yeah, we're not talking about pregnancy here. And then also pre-exposure prophylaxis. So you take it before you you get in contact with someone with COVID.
So I can go to the lake, is what you're telling me.
I mean, are we talking about that saltwater thing again? Because I thought we nipped that in the bud already.
Wait, so this is what you're speaking about now is the remdesivir?
No, I was going back to hydroxychloroquine just to say that we're still looking at it in different ways, but there's more data to suggest that using it as a treatment is probably not the way to go.
But it seems like it works for like precautionary
prophylaxis.
So why can't we take it?
It might have to do with the fact that you're taking it early, so I think we talked a little bit about kind of the toxicities that are associated with that medication, and that if we try to give it to someone who's already sick from COVID, they're already having cardiac issues and all these other issues because of the COVID. So if you put the hydroxychloroquine on top of it, it's probably not a good idea. So you're basically kind of preventing stuff from getting so severe that that you'll end up having to go to the hospital, hopefully. But remdesivir, it's a totally different thing. It's a class of medication called it's a broad acting antiviral drug. So meaning just what it sounds like it means. You can use it for a lot of different types of viruses. So one of the viruses that they've tried it for was of Ebola. Initially, before they tried it on Ebola patients in Africa, they had some laboratory data to suggest that it actually did work for Ebola. But then afterward, trying it in patients, then there really wasn't any benefit. But it's still a pretty valuable drug in the sense that the way that it works, the mechanism, it really is kind of inhibiting the genetic replication machinery that that SARS-CoV-2 uses. And so, recently there was this press release from the NIH. There was kind of some interim results of this large randomized controlled trial that's going on in multiple hospitals, where they're giving remdesivir to some patients and they're giving placebo to other patients. So it's, again, a randomized controlled placebo trial. And there was a statistically significant better recovery time for patients that got the remdesivir. And there was also a trend towards decreased death, in-hospital death to patients who got remdesivir. It wasn't statistically significant, but it was heading there. So, those are the things you want in an antiviral medication. So, so it is exciting, but and I'm hopeful that it's going to have some benefit, but we'll have to wait and see the actual published study.
Mm-hmm.
And I think no one should think of this as a game changer. That's there's no way that it's going to be 100% efficacious, meaning that 100% patients that get it are going to do well. We shouldn't expect that. And we may not. I mean, it's hard to say that if we should even expect even 50%. I think we just have to see what the numbers from the study show.
Because normally there's a very long timeline for developing a vaccine or treatment for certain diseases. Like, it's not just like you go, hey, this works, and then it just automatically takes care of everyone. So,
and I think at most what it's going to be is a bit of a Band-Aid of the current situation, and until we get an actual good vaccine, because vaccine prevents infection, remdesivir treats infection, and if you can prevent going to getting infected in the first place, that's way
totally two totally different things.
And the reaction from the public, though it can be aggravating, it's not much of a surprise, in the demand for a vaccine and these wanting to find other medication that might do something, is because people have become so impatient.
Yeah.
You know, they can't just stay inside for. I mean, if it takes a year, then just it takes a year. But you know, people are already wanting things to go back to normal.
And we're at a point where I don't think it ever will go back to being normal. Like, this is going to stick with
No.
us for a while. It's going to totally change the way we operate, just
Yeah,
socially.
I think, and there's something that that kind of sticks in the back of my mind. I've seen it a couple of times from some of my colleagues who say this, who say, you know, we keep talking about these second waves and third waves. We're not even past the first one,
Yeah.
and
Yeah.
that's what matters, at least right now. And then we can start talking about all these
Yeah.
subsequent waves.
I was figuring that we would have at least peaked before, you know, businesses and states were opening back up.
Well, yeah, I think it's different in different states.
Yeah.
I mean, if you're talking on a U.S. level, yeah, we're still climbing, and
Yeah. I think that was the hope, is that we would peak before things went back. But there's a lot of pressures from all sides for one reason or another to open or resume business or.
yeah, and
Yeah.
I mean, and I get it. I just, you know, it's a delicate balance, and you know, folks need to get to eat and get paid, but
Mhm.
to, you know, to what cost of,
Yeah.
you know.
And it's a whole new world too. I mean, the last time there was an epidemic of this, or a pandemic of this scale, you know, 100 years ago, close to it, and now we're a totally different society, like very social. Everything's connected, and so yeah, it definitely makes things a little more testy, I guess.
And
Yeah.
yeah, and in all honesty, remdesivir aside, hydroxychloroquine aside, the thing that has been the best treatment is what we just call supportive care, giving patients oxygen when they need it, you know, intubating them when they need it, because those are life-sustaining technologies. And that's kind of that's probably one of the major differences from, like, comparing it to, you know, the 1918 flu, is we've gotten so much, so many medical advances. You know, I don't even, like, and some of them have been so simple as to just turn the patient upside down, like I was mentioning earlier. Like, I don't think anyone would have done that back in the day, but you know.
Well, they might have done that, but then also drilled a hole in your head and then put leeches on you.
Now,
You know,
just because you get COVID, does that mean you're going to go to the hospital?
no, not at all.
Oh, it's just worst case scenario. So I think some people are thinking, like, hold on a second. Get the fuck out of there.
Are you yelling at your mom?
Yeah, because I think a lot of people might have that idea, is like, if I get this, I'm going to have to go to the hospital.
Yeah.
But I mean,
yeah.
what percentage of the people who get it ending up having to go to the hospital? Or is that even something that can be measured right now?
No, I mean, that's similar to the question from earlier about what percentage are, you know, the 60 and over going. I think it all depends on we just don't know the asymptomatic carriage.
Yeah.
But we could still, you know, just based off of looking at all of the different combined studies, not necessarily combining the data, but just saying, okay, this is the trend that was going on in this study. This was the trend that was going on in this study. But more often than not, probably patients are going to do well. Patients are probably not going to even have symptoms, which is the scary thing, because then, you know, they can lead to more infection to others. But so yeah, no, it's not a death sentence, you know, the COVID. But as you get older, or even having something as very common as high blood pressure. I mean, a lot of folks have high blood pressure, and, you know, they're my age, you know, and I'm in my 30s, and like it's just a common thing these days, and especially in the U.S. population, and that's been shown to be a significant risk factor, and I think that yeah, it's you know, all these risk factors, in addition to the complications from COVID, like the strokes and all these other things. I mean, they all add up, and there's actually been some studies that try to do, or try to model an actual score to tell you how well you're going to do if you have COVID, based off of, these are your risk factors. These are your lab values by the time you hit the hospital, and it'll give you a score to tell you, this is your likelihood of death, pretty much.
Jeez Louise. That's all.
All right. So we got one more. It's a longer question. It's got some backstory here. But what would be the most common sense plan to introduce our 5-week-old in real life to the world? We're on board with staying at home and isolating as long as possible, and have thus far. The unfortunate reality is that will no longer be doable in about a month when maternity time is spent, and most employers will require at least partial in-office work. Our kiddo's regular caretaker will be her 75-year-old grandparents, who will also likely be watching their other 5-year-old grandchild, and therefore exposure to that many more people through them. This still seems preferable to any other childcare option. With other people likely returning to their workplaces, the pressure will surely come for others to finally see her as well. Any advice on what you think would be the best plan of action for introducing her to friends and fam in this current landscape would be greatly appreciated. Also, if you could give me a signed note to that end that I could point to and say doctor's orders, that'd be great.
Yeah, that's a long one. That it's also hits close to home. I had mentioned last time that I have my own child who was born. I mean, she just hit 7 months now, so she was born at the end of last year. But like the majority of her life has been spent social distancing, and it's been it's been sad, and I haven't even been able to. She hasn't even seen my dad, my brother, my sister, and it's been a terrible thing, but it's the reality of this situation. And so what we ended up doing in our situation, and I can't say that this is how anyone in this situation should do it, but I can just only kind of do this anecdotal thing. And I should also preface with, I'm not a pediatrician. I think that the pediatrician would probably have more information than I can have to offer. But so there is a relative a risk of infection kind of shortly after being born. The baby's immune system's being developed. That it's before they can even get some vaccines, and we were reluctant. I think we started hearing about cases back in late January, early February, or just hearing that was a thing, and I even told Casey, my wife, who wanted to travel to y'all's neck of the woods in Dallas to, have our baby wear a mask, and I think that was probably a good idea at the time, so eventually she'll probably get or the baby will probably get their vaccines, and the majority of them come at the 6-month mark. Excuse me, it's not COVID, sorry. And I'm not saying that they need to necessarily wait for the 6-month vaccines to kind of go out and about in the world or anything like that, but those are still risk too. Influenza is still a risk, and they don't get that shot until the 6-month mark, and there's some other vaccines against common bacterial infections like Haemophilus and some other things, and there's just that those would definitely help. And one thing that also helps is, obviously getting some immunity from passive transmission from getting breastfed. But, if if the mom hadn't been exposed to COVID, then there's no reason to think that, breastfeeding will prevent baby from getting COVID. But, so I, what the biggest kind of reassuring thing that, of all these studies has been that babies and kids that get it are doing relatively well. So I think you have that kind of to look forward to. If you wanted to be the most conservative, I would say, don't have, friends and family over until, social regulations say you can. And yeah, so watching what county health department guidelines say about that. What worried me most about this question actually wasn't necessarily the baby. It was actually the fact that I know that the grandparents are going to be watching the baby and they're in their 70s, and there's been studies that have shown that, so what we call the household attack rate, meaning the chance of getting infected from someone in your household by another person in your household, or it's actually not that high for children. So they may not actually be as much of a high risk reservoir as we thought they were. I said your name again, by the way. So, but it's still a risk. And so I would just be a little bit worried and cautious about grandparents actually more than baby, and making sure that they keep up with hand hygiene, all those other things, but maybe kind of staying away from having outside visitors, that for the same reason we talked about earlier, is that we don't know where other people have been really in terms of their social interactions. So yeah, it's a vague response.
Yeah.
But again, I think just be cautious about it. Keep up with the hand hygiene. Get all the vaccines that you can, as much as you can. Don't let this whole social distancing thing prevent you from doing your regular healthcare maintenance, because that's actually even been a problem for adults. I just read something earlier today that cancer screening has gone down considerably for adults, and so if you can imagine, kind of some time from now, we might even
that
see
can have some effects down the road.
Yeah.
All right. Well, I think that was the last question. You got any others, Andy?
No.
All right, Danny. Well, thanks again.
And I want to thank the people who sent in questions before we jump off too quick. Melissa Holton, Christy May, Mike and Lisa Williams, Ashley Fernandez, Mateo Garcia, and then the person who asked about the percentages, and you said, oh, like somebody said earlier after I asked mine, that was my dad. So, Mark.
Like father, like son.
Yep. We both want to know percentages, and we want to know them now.
All right. Well, I guess we'll see how this whole thing progresses, and maybe in a couple of weeks we'll do this again.
Things are always changing, and I'm happy to be here.
We're gonna do this for years, even after it's over. People have other questions. What's that teddy bear book?
It's gonna turn into like STD talk.
Yeah.
Yeah. Let's not go there.
It's just gonna be Andy showing us things he found on the internet or his body, saying, "What is this?"
It's our new show called "Does This Look Infected?"
Oh my goodness!
People just send in pictures.
Wasn't that a Sum 41 album?
Probably
it was.
Probably. Because then we all got infected with Sum 41.
Okay.
All right. Well, everybody,
right.
wash your hands. Don't touch your face like I did a bunch during this.
I did too.
Yeah. And try to find great stuff out there. And don't share stupid stuff. And Chris, are you going to play that song as we head out?
I'll try. I'll see if I can get it.
Do
so
it.
we might be playing ourselves out with a pretty awesome song. If not, it's just gonna stop.